Okay, hello everyone. I think we're going to start now. We've got lots of people in the room. Welcome, a big warm welcome to everybody to the SPRI and Equality Insights Lab webinar to launch the new guide, which we are thrilled to be launching, the IPV Adapt Plus Framework, How to Adapt Intimate Partner Violence Prevention Programs. This guidance document is designed to support a variety of stakeholders to adapt intimate partner violence prevention programs for different populations and contexts, and includes a step-by-step flexible process, tools, and case examples. A quick introduction to me. I'm Aisha Margo. I am the Global Advocacy Director at the Sexual Violence Research Initiative. Next slide, please. So before I share today's agenda, just some quick housekeeping. We're together for an hour. It's going to be a really packed. Our event platform is Zoom webinar, and we are being recorded. Our online participants will be muted for the duration of the event. And for those of you who are online with us today, and while we're getting started, please feel free to use the chat box. We'd love to hear who you are and where you are in the world. The recording will be shared with everyone via email. It will also be uploaded to the SPRI website. We will have Spanish, French, and Arabic interpretation available. Please go to the globe icon at the bottom of your screen and then select the language of your choice. What you need to do is please press mute original language, and that will clear any background noise from the presenter on the floor so that you only hear the interpreter. I'm just going to pause a minute to make sure that everything is okay with the interpretation and people have been assigned. Okay. Next slide, please. So we have a really packed agenda for you today. First to speak is Dr. Avni Amin. Avni, it is a great honor to have you with us today. And just a quick introduction, Dr. Amin works at the World Health Organization's Department of Sexual and Reproductive Health and Research. She's the unit head of the Rights and Equality through the Life Course unit, where the work on violence against women sits. She leads WHO's work on violence against women with a focus on research, supporting countries and ministries of health in countries in the translation and uptake of WHO's normative guidelines and tools to strengthen health systems' response to violence against women. Avni is going to set the scene for our discussion by sharing some opening remarks on IPV prevention programs and the importance of systematic adaptation processes. Can we go to the next slide, please? Because I'm just running through the agenda right now. This, after Avni shares a few words with us, this will be followed by a presentation by Dr. Vandana Sharma. Dr. Sharma is based at the Harvard School of Public Health and Equality Insights Lab, and Vandana will introduce the new guidance. Vandana is a researcher who has over 15 years of experience on GBV prevention programming and evaluation in multiple contexts. After that, where we'll get this great introduction to the guide, we are going to have an exciting panel discussion, and we have three panelists, Dr. Anik Gevers, Dr. Jennifer Scott, and Emmanuel Karamage, and I will give introductions to the panelists before we start the panel discussion. And then after the panel discussion, we're going to wrap up and discuss next steps. Unfortunately, it is a very packed schedule, so we don't really have time for questions. If you do have burning questions or comments, do pop them into the chat anyway, in case we have a few extra minutes. And also, just to note, we do plan to conduct a more in-depth workshop over the next months, and then your questions will also guide us on what needs to be focused on. So now, without any further ado, over to you, Avni. Please do start us off.
Thank you, Aisha. Just checking that you can hear me.
Yeah,
yes,
we can.
Okay, great. I just wanted to thank SVRI for inviting me to share some reflections about adaptation of prevention interventions. I'm going to sort of the key for me takeaway that I'm going to convey through this opening remarks is the idea or the concept of beginning with the end in mind, and having a clear idea of where you want to go with these interventions as you think about scaling and adaptation. So what we know about prevention from the last decade of innovations and evaluations of prevention interventions is that we have a very, good set of promising interventions that have been evaluated in one setting. And now we're looking to replicate, adapt, scale, refine in other settings or in the same settings, but with wider geographic coverage. And we have summarized some of this evidence in the Respect Women framework, which is a guide for policymakers. And some of the learnings in that we learn about how to successfully adapt prevention interventions is really the importance of making sure that all the interventions put women's safety first, that there is a very clear understanding of what the core concepts and the core components of that intervention are, so that one can kind of design it with fidelity in mind. And as you adapt and scale up, I think one of the things that is important is to think about monitoring and evaluating as you go from one small geographic to another, or replicate, or expand the coverage, and really refine and adapt as you go along, because we know from all the learnings that it's not necessary that some things that's been evaluated in one setting will necessarily work in the same way, in the same to the same degree in another setting without some adaptation to context. So that's one of the key learnings from a decade or more of research. And just to give you a concrete example, and that's my last point, is really about the fact that we applied this approach in India to scale up a health systems intervention to respond to violence against women. And in the first phase, we just piloted all the WHO guidelines in training and health systems improvement components in 3 tertiary hospitals, and we evaluated it in just 3 hospitals. And it was a very simple pre-post evaluation, but we had some important learnings in that about how to build teamwork as an approach to delivering good quality care. We also had some learnings that it actually wasn't enough to just have regular health workers, but we needed specialized staff. So with that in mind, we are now scaling up to primary healthcare level. And what works too is helping us fund this scale up. And we're applying not only what we learned from the first phase, but we're also making some innovations, like adding community health workers to the training, and working with community members like the village committees, etc. So it's really, the reflections are the same, which is that you have to think about what the core component is. And in this case, we know our core component is training of health workers on first line support, which is a WHO recommendation. But we're also adding a few things that we think can enhance the impact. So with that in mind, I'll just hand it back to you, Aisha. I'm really looking forward to listening to the learnings and reflections from the others who are doing similar efforts in other countries. Over.
Thank you so much, Avni. I think that's the perfect start to get us all thinking about adaptation and all the stuff that we need to know. I'm also very excited about this this session, and I think it's going to be fascinating. We're going to just start off with a very quick video on the guidance before we hand over to Vandana for her presentation. So over to you for the video.
Globally, intimate partner violence is one of the most common forms of violence against women. Around the world, 30% of women experience physical and/or sexual violence from an intimate partner in their lifetime. Such violence is preventable. A growing evidence base shows that well-designed programs that target the root causes of violence can prevent intimate partner violence. Program staff, policymakers, and organizations are beginning to adapt these proven and tested programs to other new and diverse contexts and populations. But what are the best ways to adapt these effective IPV prevention programs for new settings? The process of adaptation is challenging. Unsystematic adaptations not only risk poor results, but could cause harm. Programs must be modified to improve fit for new contexts, while keeping the core components that are responsible for their effectiveness. Introducing the IPV Adapt Plus framework, Equality Insights Lab, and the Sexual Violence Research Initiative have developed a comprehensive guide for researchers, practitioners, activists, and others on how to effectively adapt IPV prevention programs for use in new contexts. The IPV Adapt Plus framework is an ethical and evidence-based adaptation guide that describes a systematic, step-by-step process for adapting IPV prevention programs, integrates a participatory, women-centered approach that includes learning-oriented monitoring and evaluation, provides tools for use during the adaptation process, and includes case examples to illustrate learning from previous IPV program adaptations. The guide includes 15 steps across 5 stages. The overall approach is flexible and recognizes that the adaptation process may look very different for different adaptations. The use of this guide will promote better use of scarce resources, strengthen adaptation processes, and contribute to building better IPV prevention programs.
Brilliant. Thank you so much. So there's a little taster, and Vandana, I'm handing over to you to go into more depth and answer some of the questions that no doubt everybody is immediately has in their head having watched that video. So over to you.
Great, thank you so much. I'm just going to get us to the right slide. Okay, great. Well, we're really, really thrilled to be launching this guide. It has been the culmination of a number of years of work. We have been working closely since 2020 to develop this guide and the accompanying tools. And we included a number of people on our team. So there's, in addition to myself, Jennifer Scott, Catherine Bellin, Liz Dartnell, and Anik Gevers from SVRI. And we also had a 14-member advisory board. Now, just to kind of get us all on the same page before we dive into sort of what the guide contains and how it can be used, let's just review what we mean by adaptation. And so the definition that we're using in the guide is that adaptation is the deliberate and planned process of modifying the content, delivery, or implementation of a program to optimize its fit for a different context or population. And so Avni was talking about the core components of a program. During an adaptation, it's important that we uphold those original core components to achieve the intended impact of the program. And those core components are the features of the program which fundamentally define the program and are responsible for the desired effects. Some other concepts that come up frequently when we're talking about adaptation are fit and fidelity. Fidelity refers to the degree to which a program is implemented as intended by the original developers, while fit refers to how closely the program is tailored to a particular context. We often hear about fit and fidelity being described as being on a continuum where increasing one, so increasing fit, for example, will reduce the other, so fidelity. But in fact, in reality, based on our learnings, that relationship is actually much more complex. And so our goal, however, during an adaptation is to increase the fit while maintaining the fidelity. Both are really essential to a successful adaptation. And during the process of developing this guide, we identified a number of different types of adaptation, and these are covered in the guide. But there can be adaptations for a new population, but also some IPV program adaptations are adapting for a new modality, and they may be in the same population or context, but they're changing the way the program is being delivered. For example, from an in-person program to a tech-based or a podcast-based intervention. There are also adaptations from a non-humanitarian to a humanitarian context, adaptations that are part of scale-ups, and adaptations to address new issues. And so overall, across the work that we have done over the last 3 years, some of the sort of key things that are important for effective adaptations are listed here on the screen. And we'll be able to get into more of details around these and with some real examples during the panel discussion. But fidelity consistent modifications are really important. So those changes that compromise fidelity may also reduce effectiveness of the program. Adaptations that use a systematic process tend to be more successful. So those include consulting data, stakeholders, theory, or other approaches that may be more likely to adhere to a program's core components. And then adaptations that are proactive or planned. So that means they're made in response to an anticipated obstacle, change, or difference in context. Those tend to be more effective than reactive or unplanned modifications. Now, those can also be done in a systematic way that may not threaten fidelity. And then ineffective modifications often occur in the context of limited available resources and or time, or when modifications have been unplanned or unsystematic. And we definitely need more research to understand how different types of adaptations influence program outcomes. So with that, I'm going to introduce you to the framework. So it's called the IPV Adapt Plus framework, and it comprises 5 stages and 15 steps. Now, IPV stands for intimate partner violence, as you all know, but it also stands for intentional, planned, and validated. And that's because our framework that we're presenting outlines a deliberate and planned process to facilitate IPV program adaptation. And it seeks to avoid unintentional deviations and on-the-fly adaptations. It's a systematic approach, and there are validation checkpoints integrated in the process. Now, the plus refers to the additional cross-cutting principles that are taken into account across the framework. So that is ethical principles, community-based, participatory, and women-centered approaches, and learning-oriented monitoring and evaluation. Now, while this framework is presented as a process with 5 stages and 15 steps, it is a flexible approach that recognizes that the process might not be linear. And so the guide is designed for use by researchers, practitioners, policymakers, and also it's useful, I think, for funders. And I've just kind of summarized down here some of the review of articles, the informant interviews, and input from key experts that went into the creation of this framework. So here you have the framework on your screen. It's currently available in English, but also in French, Spanish, and Arabic. The way that it's organized is that there are 5 key stages, and each stage is represented there by the acronym ADAPT. So A is the stage 1. So it's assessing the context and selecting your IPV prevention program that you'd like to adapt. D is the second stage. That's designing your IPV program adaptation approach. And underneath that, there are the 3 steps that go into that stage. The third stage is doing the actual adaptation. And so that's modifying the selected program components, it's obtaining feedback on the adapted materials, and it's documenting the process. The fourth stage is P, and that's for piloting and refining the adapted program. And under that, there are a couple of steps. And then the last stage is your targeted implementation and evaluation. And under that, there are several stages as well. And so I mentioned these core principles already, but we've just sort of described what they are here. So for the participatory community and women-centered approach, this is integrated throughout the process to ensure acceptability, sustainability of the adapted program, culturally appropriate content, and also ensuring that women's voices are at the center. We've also highlighted some elements to ensure that an equity lens is integrated. On the ethical and evidence-based adaptations, Here, the important thing is that the adaptation process and implementation of the adapted program should not cause harm to women, community members, or partners. And so safeguarding mechanisms should be in place to monitor and mitigate risks. And then the framework also emphasizes adapting IPV programs that have already demonstrated effectiveness. And then on the learning-oriented monitoring evaluation component here, the framework and guidance emphasizes the importance of documenting the adaptation process and monitoring and measuring the effects, and here we mean both unintended and intended effects of the adaptation during piloting and also during program implementation. The framework includes a theory of change. I will not go into detail here, but I just wanted to mention that the theory of change focuses both on outcomes related to the adaptation process itself, as well as outcomes related to implementing the adapted program. And we've also included considerations about how the adaptation process and timeline are sort of aligned with funding timelines. And so we've included some helpful guidance on that as well. And then finally, I just wanted to touch on the fact that the guidance includes some tools and case examples as well. So one example of a tool is a modification matrix. This is included in the guide and includes a completed version as well, so you can see what that looks like. But basically, the modification matrix is a tool to help identify and plan and document what specific changes are made during the adaptation process. And here's an example of one of the case examples that we have included. There's quite a few towards the end of the guidance that focus on very different program adaptations and explain sort of what was done and then pull out some of the key learnings. So this is an example from the Unite for a Better Life program, where it was originally designed for a non-humanitarian setting, so rural communities in Ethiopia, and it was adapted for a refugee context. So this case example highlights some of the learnings around, how do you effectively adapt from a non-humanitarian to a humanitarian context. And so with that, I am going to hand it back to Aisha, and I'm really excited for us to delve into the panel discussion.
Wonderful. Thank you so much, Vandana. I think that's given everybody a great overview, and it's going to be really interesting because we have a really exciting group of panelists today. They have a wealth of experience and expertise to discuss adaptation and from their experiences, and also to provide some concrete examples of some of what we've heard. So I'm just going to quickly introduce our panelists and then, go straight into the discussion. So we have Dr. Anik Gabus, who's an independent consultant with expertise in prevention programs and interventions. She's provided technical support to many teams around the globe in adapting such programs and has co-authored the framework that we're discussing today. And she'll be sharing some experiences primarily from her experience of supporting adaptations of Inda Shakirwa in Lebanon and Iraq. Dr. Jennifer Scott is an assistant professor at the Harvard Medical School. She has 15 years of experience focused on GBV prevention, response, and risk mitigation, primarily in conflict-affected communities. And she'll be sharing insights from her work on adapting Unite for a Better Life to a new modality, from in-person to a podcast modality, and from a non-humanitarian to humanitarian context. And Emmanuel Karamage is the coordinator of Banda Bereho Scale-Up Program, which has engaged men in caregiving and violence prevention at the Rwanda Men's Resource Center. Emmanuel has more than 15 years of working experience in the domain of gender equality, women's empowerment, sexual and reproductive health and rights, and in engaging men and boys in GBV prevention, caregiving, and maternal and child health. So I don't need to say anymore. I know you're all really interested to hear from them, and I'm going to stop talking. But let me go straight to the first question. And I'm going to ask, okay, well, let me ask a question. So the IPV Adapt Plus framework highlights, as we've heard a little bit about, many good practices for adapting IPV prevention programs. This is from ensuring adequate resources, to allocating sufficient budget and time, to ensuring the core components of the original program are not modified. In your experiences with IPV prevention program adaptation, could you share one or two good examples or examples of good practices for conducting effective and ethical adaptations? And I'm going to ask all of you the question, but Anik, may I start with you, please?
Thank you, Aisha. It's really great to join everyone today. So I'm referring specifically to two UNDP projects, one in Lebanon and one in Iraq, who chose to adapt in Shakira after looking at a host of available options, evidence-based options. And this was one of the components that they chose that was part of a broader effort to integrate ethical and effective actions to address GBV within large-scale sectoral projects. So within those two projects, a couple things are really helpful. First of all, it was helpful to the Iraq team that the Lebanon team had started earlier, and so there were a lot of lessons learned that they could pick up on. But for this intervention in particular, it was incredibly helpful to have a fidelity brief, which was already available, and also being able to engage directly with team members from the original group who both developed and were involved in the RCT, or the randomized control trial of Shakira in Rwanda. That was enormously helpful, and there was sort of ongoing engagement. So they were very generous with their time and expertise in sharing with the team who were working on the adaptation. The other thing that folks found very helpful with that adaptation process was that it was a team of people who worked on it. Not only one person was responsible for it. And this ranged from people at the local and community level where the intervention was going to be implemented to the national level. There were multiple people at the national level involved, as well as then a couple of folks from the international level, who all brought different kinds of expertise. And ensuring that all of those people at all of those levels were flexible and creative was really important, obviously within the bounds of fidelity, because there were multiple complicated factors and contextual factors that needed to be brought into the adaptation, as well as situations in which a reactive approach was necessary because of multiple unforeseen crises, including COVID, that happened after the adaptation was well underway. So, like Vandana said, sometimes it's not possible to always be proactive, but when you are thrust into a situation of having to be reactive, that's where it was really helpful to have a team involved in trying to make very thoughtful decisions and balancing the very many moving parts that we had to balance. So I'll stop there and let colleagues share, but that's just a little bit about what helped us in that situation.
Great, thank you. Yeah, it's actually amazing how when you actually start hearing about concrete examples, it really brings things to life and creates a different type of understanding. Emmanuel, would you like to comment on this?
Yeah, thank you. Just to inform you that Indashikirwa was piloted in Rwanda for the first time. But I wanted to present on Vandevi level, which means a father who is a role model in the community. Vandevi level is a program that engages men in maternal, newborn, and child health, in gender equality and violence prevention, but also in caregiving. It has been adopted in Rwanda in 2013. The original program was implemented by Equimundo in Brazil. Then it was adopted in Rwanda. We have many adaptations. We are now scaling up, but we tested the program in the pilot phase. we started by formative research to assess and to understand the Rwandan context, let's say the local context. And then we use the participatory approach for creation of women's safe space, because we are focusing on couples, but we are aware that violence prevention is targeting mostly women and children. And then we use the participatory approach to assess and to understand more the condition and even other exposing factors for GBV to women and for children. We engaged with the government in content development, and then we gain approval from government side. And maybe I would like to precise that we are working together with Rwanda Biomedical Center, which is a government institution in charge of overseeing what we are doing at community level, because we are responding to the government issues. And then we tested the materials to avoid the harm, either for women, either let's say we focus more on decolonization to avoid the fact that this program is borrowed maybe elsewhere in the world, and we tested it, and then we revised it to avoid the harm. And we did evaluation, and we did also a post-evaluation after 6 years follow-up. After 6 years follow-up, the intention was to assess the long-run sustainability of the positive outcome, and we found that the outcome are still there. One of the advice from my perspective is to respect all the steps of adaptation, and to respect all the steps of adaptation, so that we make sure that we are not jumping the step, and even we are not trying to shorten the program. When we adapted the program, rely mostly on the original program for the purpose of the quality and for the purpose of the fidelity. When we are adapting the program, you can adapt for one context and then adapt again and then adapt, and then you lose the original context. It's as if we are implementing something else when we compare the adaptation and then the original program. I think in short, I can say that what we did, and we are now we conducted after the pilot, we did a transition to scale to assess if the original pilot can be replicated in other contexts. Now we are scaling up through the government health structures of community health workers. We are covering the 3 districts of Rwanda using the government pathway of community health workers. And we are still keeping the quality and fidelity. We are still going back in terms of monitoring and evaluation to assess the challenges, to assess the problem that may occur during the implementation. But the results are almost the same when we compare where we are now with the pilot phase. Thank you.
Great. Thank you so much, Emmanuel. And I encourage you all to, there's some really interesting points coming up. And if each of the panelists wants to respond to another panelist on specific points or ask questions about that, then please feel free to do that. But for now, Jennifer, would you like to comment on this first question?
Thank you, Aisha, and thanks, Anik and Emmanuel, for sharing your perspective. I think I'll comment on the question from the perspective of being involved in the adaptation of Unite for a Better Life, as Vandana presented. We adapted UBL from a non-humanitarian context to a humanitarian context in Ethiopia. And I think the best practice that I could identify was really the systematic and participatory approach to the adaptation and the documentation of the adaptation process. And one of the key aspects of that we were fortunate to have was engagement with the original developers of the intervention. And I think that's key to really identifying what are the core components of this intervention that should be maintained through the adaptation, and then bringing in the perspectives of the formative research, of the work that was done in the new project and the new adaptation, bringing in those elements and coming together. We planned a workshop where the workshop was focused on adaptation, and we looked at the original theory of change. We looked at the formative research results. We brought in the perspectives from the original developers and the new context, and we're able to document systematically what changes were made and what the decision-making process was around that. And I think that's one of the reasons why we developed this guidance note, was because a lot of those decisions are lost in the adaptation process and don't get communicated. And so then when future people groups or governments are implementing these adapted programs, it's not clear exactly the sort of storyline between the original intervention and this adapted version. And so I think the best practice that I could identify from that was really this building enough time, having a systematic approach, which included engagement of the original developers, and then having some type of participatory way of approaching those changes and then documenting them. And the guidance note has some tools for supporting the documentation of the adaptation as well. So I'll pause there. Thank you.
Some common points coming out there from all of you, actually. So as the authors of this guide, many of you actually were capturing learning on IPV program adaptations to inform the framework. Programmers and practitioners did speak about, different challenges that they had dealt with over the course of adaptations. And I think you've all actually started touching on this already, but are there specifically, maybe, is there some one or two specific challenges that you've encountered in your experiences that you would like to speak about, and how you overcame those challenges? And Emmanuel, I thought I would start with you this time, just to mix things up and make it a bit unpredictable.
Thank you. The most challenge is that the adaptation to take a lot of time, because we need to assess, we need to understand, and we need to adapt to the current context. And for most of the implementers don't want to have a project that will take a lot of time. Another thing is that because we need to have something which is documented, we need to generate evidence. And on the case of Vandevereho, we decided to use randomized control trial, where we compare results from treatment and control group. The research is normally very expensive, and most of the donor and most of the implementers wanted to avoid that part of evidence generation. They are relying on the monitoring and evaluation findings, but we need to dig more so that we understand if the program is effective and is providing long-run sustainability of outcome. And apart from that, we have to keep the all content from the original project. Most of the implementers, I have been in discussion with most of the people who would like to adapt and to implement to adapt in the new context. They wanted to use the shortcut. But if you remove one component, remember that you are also removing some outcome related to the original intervention. I would say one of the challenge, the most critical challenge is most of the people intend to shorten the program, to adapt by shortening the program. because sometimes it is very expensive. It require money, require time, require researches, and the people intend to shorten the program. When you shorten the program, the quality and the fidelity is not the same. We are implementing something else because we are not adapting. We are creating new content in the new program, which is totally different with the original one. When we are looking to the original one, we are relying to the same level of outcomes. We are tracking the same level of outcome from the pilot to the adaptation and even to the scale up. We need to have the same uh, level of outcome, so that we need to keep in mind that adaptation is not something which is easy, but also it takes time, but also it can take a lot of money, but also it needs the dedicated staff who are tireless work on the different phases. I think in short, that I would say on the challenge that we faced during the adaptation and during the scale up.
Great. Yeah, absolutely. I mean, that does sound very, just very quick follow on to that. I mean, so when you faced this, did you, were you able to overcome this like instinct to take shortcuts, cut budgets, cut money, cut time? Was there a way you were able to overcome that in your own project or that you saw happening around you?
It is not easy. Sometimes we 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 decide even to avoid some money from some donors whom they wanted to shorten the program. And we said we cannot do that. We are relying to the original project. And when we are integrating the program into the existing government structures, and because it's high cost, the government would like to shorten the program. And we said, let's maintain the quality, let's maintain the fidelity. At the same time, we are maintaining the same level of outcome. As per now, we are protecting the level where we are compared to where we come from, so that, but we keep in mind that if government decided to implement the program alone, I think they will deal with the program. Absolutely. We keep in mind, if government decided to implement the program, it will not allow us to control the program while it is implemented by the government. We are aware maybe we will experiment some changes in even deviating the program.
Great, thank you. Thank you for sharing that. That's really interesting and does sound very challenging. Jennifer, can I pass that question to you?
Sure, thanks, Aisha. So to respond to the question about challenges faced, I'll share some perspectives from the adaptation of UBL into a podcast format. So as you know, we adapted the UBL from a non-humanitarian to humanitarian and had these different considerations, such as how does displacement influence stress in relationships and intimate partner violence. And so we tried to address those in that initial adaptation. And then we consider that humanitarian context, people may not have the opportunity or the sort of investment emotionally to be able to sit in sort of group-based in-person sessions. And that was the original format for UBL, was to bring groups of women, men, and couples together to discuss, a sequenced curriculum addressing all the components that lead to intimate partner violence prevention. And so when we were considering how to best deliver this in a humanitarian context, we adapted the program to be delivered as podcasts. That way people could have the opportunity to listen at their own speed, at their own time, and in their own space. And so we went through the same systematic process of adapting, but I think the question that came up and the challenge that we had was related to fidelity. And the question that we would ponder was, was this really an adaptation of UBL, or was this becoming a new program? And so we had that challenge before us around this fidelity to the original intervention. And I think, again, having the original developers engaged in this process was extremely helpful, but at least being able to identify what are the core components. And that takes time, to be able to say and to stick to those. And so for us, it was, having this participatory skill building. The UBL is delivered in the context of a cultural ceremony or community practice. And so we wanted to maintain that even if we developed a podcast, that this could still be delivered as part of tea talk, or bringing people together to listen even to the podcast as a group, not just individually. And that it relied on community engagement. And so we still identified the core components of the original intervention and tried to maintain those as we made this adaptation to the podcast format. But I would say that was probably one of the core challenges that we experienced in doing that I'm sure others can relate to as well. Thank you, Aisha.
Thank you, Jennifer. And Anik, we'd love to hear about what you have to say on this.
Thank you. So I will just say that at the time of working on these Shakira adaptations and ones before, and other adaptations before that, there wasn't this guidance. And so there was a lot of reliance on trial and error, and a lot of reliance on getting multiple experts on board, and needing quite a lot of input from them. The other thing that was not yet released at that time was the research around the common elements of effective prevention programs, which is very, very useful. Not only the fidelity to specific models, but to understand more broadly what is effective in this type of programming and interventions. And so primarily, much like Emmanuel discussed, the time and budget for the adaptation process was just entirely inadequate. The folks who did the planning before they got others involved just didn't know what they didn't know, and so didn't know that this would be such an intensive process. Also working with many non-GBV specialists, because it was integration to large sectoral programs, meant that a lot of advocacy was needed, both internally by the GBV or gender focal points, as well as all the additional experts that were brought in around ethical and safety concerns of doing this kind of work. And also doing the larger sectoral work. How does one do that in a GBV sensitive way? And to really build the understanding around the evidence and the core components. And again, this is why having a team was really helpful, because we could have really robust discussions when we were pushed on things like wanting to take shortcuts around various things, as Emmanuel was talking about. So what will happen if we make this compromise? Sometimes there was data in terms of Shakira. There had been the RCT with CARE and Through What Works, and there had been another rollout of it that had very different results. And so we were able to understand what drove the undesirable results and what drove more desirable results, again, because we were able to engage with folks involved in the original intervention development and rollout. So I think those are really important aspects and sort of challenges. The other thing that happened within this experience of adapting Shakira in Lebanon and Iraq was that, as I mentioned earlier, the COVID-19 pandemic swept across the globe. And so all of a sudden, an in-person group-based intervention had to be fundamentally changed. And so, as Jennifer was saying, is this an adaptation? Is this something completely new? Because that group relationship and the group process is so fundamental to the change, or we thought. there was also multiple economic and political crises, multiple safety and security, localized security concerns that meant that certain, I suppose, implementation things had to change. And also because of COVID, the plan to support the facilitators in the communities had to be changed. It could no longer be in person because people couldn't travel to that area of the country. So some of this was unprecedented, but you know, we had to sort of make a plan. And again, that's why the team was so important, that everybody has each other's back and can have somebody to bounce ideas off of, and for somebody to be able to look at the, you know, to have the evidence base in mind, and for somebody to have the local context in mind. Language, so not specifically for this adaptation, but previous adaptations that I've worked on, is that language on translation is extremely challenging, especially when not all members of the multidisciplinary team who are working on the adaptation speak the language within which it is going to be adapted. Because even very professional translation services did not always get the context or the spirit with what is meant across. So, for example, in a parenting program that was also aimed at violence prevention, the concept of positive discipline, the way that it was translated for a setting in Asia, actually was understood to be corporal punishment, which is completely the opposite, obviously, of what was trying to achieve. So a lot more, I think, effort and time needs to go into really workshopping the language and the translations to ensure that the spirit and the meaning, not just the words, is really quite specific and stays true to what the original work wants to do, which can be very difficult when you're talking about social norms, sometimes unseen social norms, or social norms that are not often challenged or discussed, or issues that can feel quite abstract, like challenging power structures and relations, and just sort of matters of identity, which is all issues that this work touches on. So it is important to be very thoughtful, I think, about the details.
Yeah, those are great points. And I see that we are actually in our last few minutes, so I'm going to have to draw the meeting to a close. I'm very aware that we could talk about this for at least another hour without pause, and there are so many complexities in it, and it just makes me think more that let's celebrate having this amazing balance, which I think is going to be so incredibly helpful to the field, and also help people. I mean, I think one of the core complexities is also this question of working out, you know, what are the core components that you absolutely cannot change, and how do people grapple with that? And we haven't even been able to get to discuss that question really. But thank you so much to everyone on this webinar, and all our panelists for answering our questions. Thank you all for joining us. We are, of course, going to share the recording. We have shared with you the links for the guidance, and you can download the full document in English. The executive summary and the framework have also been translated into Spanish, French, and Arabic. And we are definitely hoping to run a more in-depth workshop that will cover in greater depth some of the questions that I'm sure many of you have on the sort of how to, when it comes to conducting IPV program adaptations. We will definitely also be running an intensive in-person workshop during the next SVRI Forum, which is in October 2024 in Cape Town, South Africa. So all of you start planning to join us now. And please do reach out if you'd like to discuss adaptation, or you'd like to explore new collaborations or evidence generation around IPV program adaptation. Vandana's email address is on the screen. Please do feel free to email her with questions, comments, and ideas, or email any of us at SVRI. And many, many thanks. Thank you so much to everyone again. And extra special thanks to all our speakers. I think we finished on time. So if anyone has any last, I think there's 1 minute, and hopefully you're all getting the addresses and the links that you need from the chat. So feel free to get all of that before leaving this event. There are lots of links coming up in the chat. So yeah. But as I've said a couple of times, this recording will be available to everyone to listen to again and to get these resources.
Aisha?
Yes.
Oh, thank you for moderating so well. I just had one suggestion for SVRI. You might want to consider doing this session with donors, because I think a lot of these issues that are coming up are also related to how donor funding is structured. So it might be helpful for them to hear some of the reflections on how funding needs to kind
Absolutely.
of accompany, the process of scale.
That's a brilliant idea. Absolutely. Thank you, Avni. Okay, and I think we're going to be closing the room now. So final goodbye to everyone. And thank you again.